So we do an extensive surgical debridement of all the involved structures. It could be a part of the nose, or it could be a part of the paranasal sinuses, a maxillary bone, or the jawbone, the orbit, or the palate, anything which is involving it. And we send the specimen for fungal examination, fungal culture, and also for the biopsy. So now here comes the question: what is the rationality of surgery? Many of the common people, they were asking, why do we need to go ahead and perform a surgical procedure? Why can't we just medically manage it? Go ahead with the antifungal medications, which can directly kill the fungus. And this is why we emphasize more on surgical procedure, because we know this mucor fungus, it invades the blood vessels, and after it invades the blood vessels, it causes thromboembolism, and this cuts off the blood supply to the tissue, and this leads to tissue necrosis or the death of tissues, which leads to gangrene. And this antifungal medications, whichever we are giving to the patient, it cannot be penetrated into this dead necrotic gangrenous tissue. And because this good penetration, for this purpose of good penetration of antifungal drugs, it is really very important to completely eradicate, to completely remove the necrosed tissue surgically. So basically, for the good penetration of the antifungal medications, we need to go ahead for surgical debridement. And not only for that, we are reducing the fungal load in the body. So we are removing the necrosed tissue from the involved site, and when we are removing this necrosed tissue, we are basically removing the amount of fungal load in our body. And of course, because we have removed much of the fungal load in our body, this reduces the dose of the antifungal medications which we are giving to the patients, and also the duration of time these antifungal medications are to be given for a patient is also much decreased when a good surgical debridement is being done. So, with that being said, I'm proceeding with the surgical procedures which are done on our patients. So, the two MRI CT scans which I placed, and I'm not placing very gross surgical videos on this online platform. I know it's very disgusting. So, yeah, this is how it looks. This is the endoscopy picture of the right side. I'm just proceeding with the surgical video. So once again, this is the endoscopic picture of the same patient, the first patient which I placed. This is the right-sided nasal cavity, and we are able to see the entire necrosed tissue, necrosed middle turbinate, and we have exposed the middle meatus area also. Now we are cutting off the middle turbinate, and here I'm not using any powered instrumentation, because this specimen which should be for sent for fungal examination should be very handled with delicacy, because the hyphae and all, they get disrupted. So we did not use any micro debrider in this first. And right now I'm just removing all the dead and necrotic tissue with the help of a micro shaver or a debrider. This is a powered instrument which we use in all our endoscopic sinus surgeries. And you can, as you can observe, the entire bone is extremely friable, and the entire tissue is completely avascular. And right now here I'm using a coablator, and this coablator is mainly used to provide a bloodless surgery. And this step is mainly to access the lateral wall of the nasal cavity, and to directly enter into the maxillary sinus area. And what you are able to see is the anterior border of the pyriform aperture. And this bone, which separates from the lateral wall of the nose to the maxillary sinus, is being drilled off with a drilling machine, which it's a nasal drill which we use in our endoscopic sinus surgeries. And this bone, as you can see, it is completely drilled off. And this procedure, we call it as medial maxillectomy. And if you can observe, there is no incision which is given from outside. Everything is being done from inside, and this is being done when the patient has a limited disease. And now you could see the entire maxillary sinus, the interior of the maxillary sinus is completely exposed, and the disease is entirely removed. And you could see that's the nasopharynx area. So why do we widely open this is not just for the disease clearance but also for the post-op surveillance, so that we could see the entire nasal cavity and the maxillary sinus in a single go, at a single glance, even in the post-operative period, so that we could give repeated washes and remove out whatever are the crusts which are seen. And that's the opening of the sphenoid sinus. This is the skull base area, whatever you are able to see, and this is the interior of the sphenoid sinus. This is the skull base or the sella turcica, and here we will be able to appreciate the optic nerve if we go inside. Once we cut open that, we are directly into the middle cranial fossa. So that's the first surgical thing. And this is another case scenario. Now I'm on the left side nasal cavity, and I'm using an angled endoscope and visualizing the maxillary sinus ostium. Well, this is once again a minimally invasive surgery which is being done. You could see the bits of fungal tissues which are being removed. I know this is extremely gross, but because this platform is meant for doctors, I just place this video straight away. And we remove the entire fungal debris this way. This is the interior of the maxillary sinus. Once again, I'm using a 70 degrees endoscope over here. Once all the fungal tissue is being removed bit by bit this way. So that's the interior of the maxillary sinus. You could see some edematous tissue and some amount of pus there, some ulceration also. And this is what was appearing hyper intense on T2 MRI. And those are the fungal tissues which are being taken from the nasal cavity. And you could see this is the nasal cavity picture on the other side. On the right side maxillary sinus, once again, this patient had some fungal debris on the right side also. And these were appearing once again hypo-intense on the MRI. If you remember, I kept the MRI of the same patient in the previous slide of mine. And this is how we remove it. Bit by bit, it is broken. So the entire contents are scooped out this way. So that is how the fungal elements appear inside our nasal cavity. So after this entire fungal contents are removed, we give a thorough wash and post-op surveillance will be made. And these pieces are sent to fungal culture, biopsy, as well as fungal examination. So this is our OR, operating room, and this is the final image how we get after a minimal invasive surgery with an endoscopy. You can appreciate that all the sinuses are being widely opened here, and that's the skull base. And we use a navigation equipment at our center, which is like a GPS for our cars basically, and it guides us exactly where we are. See, this gives us X, Y, and Z axis, and this is on the other side nasal cavity on the right side. And you could see all the tissues are well bleeding, they're completely vascular, and still the very good job is done being exposing the entire skull base, and the entire right maxillary sinus is being widely opened. So this basically avoids lots and lots of morbidity for the patient, but still doing an excellent job. That's the importance of early diagnosis and early treatment. The prognosis will be extremely good. Always remember, once again, the surgeries whatever we are performing are tailor made. So if only one sinus, if only the maxillary sinus is involved, we perform a endoscopic sinus surgery with a medial maxillectomy, what I have shown earlier. So this bone will be entirely removed and all the contents will be drained out. And if the sinus as well as the orbit both are involved, we do a medial maxillectomy and also an orbital wall decompression. It could be medial or inferior orbital wall decompression when there is a good vision being maintained by the patient. When the sinus and also the orbit is involved and there is no vision for the patient, we do a suprastructure maxillectomy where we do the upper part of maxilla is being removed and also entire orbital excentration. The orbit will be entirely removed because there is no vision, there will be of not much use. And when the sinus and the palate, the partition wall which separates from the nose to the oral cavity is involved, only these two are involved and the lower part is involved, lower part of the sinus is involved, we do an infrastructure maxillectomy. Sometimes if the maximum part of the sinus involved, we give a proper Weber Ferguson incision and we remove the maxillectomy proper. But only if the inferior part of the sinus is involved, we go ahead with an infrastructure maxillectomy where the lower part of the maxillary sinus and the palate is being removed, and once again it will be reconstructed with the obturator. And once again, if the sinus, the sinus, the orbit, and also the palate and even the brain is involved, we from the ENT surgeons, we do a total maxillectomy, and the oculoplastic surgeons will be doing, I mean, ophthalmologists will be doing a complete orbital excenteration, and the debridement, surgical debridement of the brain will be done by a neurosurgeon. So always these surgeries are just tailor made. So, do you think this is the end of the situation? Absolutely no. After the surgical procedure is done, the patient will be taken over by the physician or an infectious disease control specialist. So, once the biopsy report is out, the fungal culture specifically states that the patient has mucormycosis and the fungal stain, everything has come out to be mucormycosis. We hand over the patient to the physician, and the physician will be starting the patient on IV Amphotericin B, which will be given for a minimum of 14 days period for a good antifungal coverage. And in the meantime, we ENT surgeons keep checking the status of the nasal cavity, how is the cavity healing, and also do a serial nasal endoscopy, check the clinical status of the patient, etc. And we also send the patient for serial MRIs. We, in the meantime, we check the CRPs, the C-reactive protein of the patient, the liver function tests, how are the ESR values, are they elevating or it's being maintained. And if everything by God's grace is good, if there is no disease recurrence, if the serial MRIs turn out to be good, then the step down therapy will be started by your physician, where the IV medications will be stepped down to antifungal medications, and mostly they'll be given for about 3 months, minimum of about 3 months.